First of all, can I welcome everyone who's joined us from the public. I'd particularly like to welcome a group of young carers who are joining us today. It is Young Carers Awareness Day today, and they'll be spending a bit of time with us at the end of the board meeting just to share with us some of their experiences and help us learn what we need to do better to support them. So welcome, and welcome everybody. I should remind everyone that this is a board meeting in public, not a public meeting, which means that we don't take questions during the meeting, but at the end, when the meeting's formally closed, David and I will be available to take informal questions from members of the public who've taken the time to listen to us all. With that, I think we've got apologies from Andrew Morris and Noel, I think. Is that right? Noel Gordon, who's joining us later. Are there any further declarations of interest that we need to add on?
Just on my list, I am now the chair designate for the South East London Integrated Care System, so I start formally in February.
Congratulations, Richard. Thank you. Are there any comments to the minutes from the meeting on the 28th of November? I'm sorry that we missed you, so to speak. Well, we'll correct that right away. Excellent. I should add that item 9 on the agenda is an NHS England board item only, so I will chair the meeting up until that point and then hand over to David to chair that piece. So with that, David, is there anything you want to say in your chair's update?
No, well, I'll leave it till later. Thank you.
Okay. For me, all I wanted to do, I try and make a point of saying what I've been doing out and about. I've been to 3 different but all rather amazing clinical teams in the last few weeks. I spent a morning with Oliver Warren, one of our colorectal surgeons, in his operating theatre and with his team in Chelsea and Westminster a couple of weeks ago. I was in Bromley by Bow, the community centre, with Dr. Sam Everington and his team, and lived up to their fame and was fantastic, but also slightly different. Last week I was on Monday, I was in Nottingham with their catering team. Nottingham has one of the best catering services in the country. Over 65% of all their produce is British sourced, and I was with the Love British Food team learning, and one of the things they do is their board tastes the patient's food very regularly. And it's the first time I've visited an NHS institution where I had lunch eating what the patients were eating that day, and it was really good. So just to keep that on the record. With that, shall we move on to maybe the more important clinical items on your agenda, Simon?
Thank you, Dido. I just mentioned 2 things that aren't covered elsewhere on the agenda. The first is that obviously we are stepping up our action for coronavirus readiness. The NHS is embedded in the cross-government COBRA process. This detect and assess phase, so-called, is being led by Public Health England and the Chief Medical Officer under the aegis of the Department of Health and Social Care, but we're also stepping up NHS readiness, and Keith Willett is our leader on that. The other thing I was going to mention is I'm pleased to say that today we are confirming the appointment of Emily Lawson as our National Commercial Director for the NHS. Emily's done a fantastic job up until now, including in terms of bringing together NHS England and NHS Improvement, while also supervising some of the commercial functions. And so that means that we will produce some other changes internally, including bringing together the internal HR and people functions with the NHS-facing people functions that Verena will carry on leading. But we are grateful to Emily for stepping up to this new challenge.
Yes. Well done. Thank you, and well done, and good luck.
That was it.
Okay.
I think the rest, we got the 2020-21 planning guidance, we got current performance, we got lots of juicy specialised commissioning topics, so
we've got a
let's go with
agenda. Okay, so with that, shall we move on to an update on operational and financial performance? Amanda, are you going to kick us off?
Thank you. First thing to say is just obviously the information that we're talking about today is previously published data, so this is all in the public domain, so everybody will be aware that particularly that it remains very busy. I think the things that we do want to highlight as particular positives, though, against a backdrop of, being very conscious of how hard colleagues across the whole of the NHS continue to work, is just the great progress that we continue to see around mental health. So that's incredibly encouraging. And in relation to urgent and emergency care, although Pauline will talk more about what's going on around the transformation agenda in urgent emergency care, I think we would just want to say, I think, a particular thank you to Anthony Marsh and the work he's led on the creation of the Ambulance Coordination Centre, which I think has felt like it's been a very important, I suppose, way of giving us real confidence in safety for our patients over this winter. And then secondly, just a thank you to all of our colleagues in the NHS who have worked really hard to make sure that we have been able to open the additional beds that we talked about back before Christmas, which are definitely allowing us, I think, to begin to see some encouraging signs in January. Final thing to say is just we are running in, of course, to the end of the financial year now, so we still have a couple of months left to really try and bear down on some of our key priorities around performance. So in particular, it's a real encouragement to focus on doing as much as we can around learning disabilities, where we have seen great progress, but we have further to go. And the other area for particular attention is those patients who are waiting 52 weeks for elective treatment, so routine care. But we know that the standard we are all committed to is to have no patients waiting that long. There still are some, so a real focus on trying to get that down as much as we can in the next couple of months.
Fantastic. Julian, do you want to follow on?
On the financial position, in month 9 forecast, which we have only just consolidated in the last few days, we are beginning to see, well, I think we are really seeing a set of commissioners and providers now forecasting where they are going to deviate from plan. It's basically coming in line with our expectations. Our current forecast is that at the end of the year, in aggregate, we think the balance of commissioners and providers will be about 400 million off plan. As I think I flagged last time, bear in mind that's like 0.5% against the total spend. However, although it's not encouraging that not everyone is on plan, the number of organisations which are forecasting to be off plan is roughly half what it was at this point last year, which I think does show progress in delivering the financial trajectories that were agreed, even if there is more work still to do. And we are working hard with regional teams and systems providers and commissioners to continue to try and improve that position. And we are managing the risk, though, that poses to the whole NHS mandate, in part through having gone harder this year at our own admin costs for NHS E&I, and in part because of slightly lower than originally forecast drugs spend, which is also a reflection of a lot of the commercial work that has been done over the last 2 years by the NHSE and I team. Worth saying on capital, against the allocation the department have made, we are forecasting to be within 100 million or so of that allocation, and we continue to work with NHS organisations to make sure that funding provided is spent. And as we'll come on to maybe on the operational planning guidance, we are also continuing to work on the process to speed up the whole approvals between systems, ourselves, the department and the rest of government.
Fantastic, thank you. Pauline, would you?
So just starting off looking at our headline performance for the month of December, emergency department attendances had increased by 6.5% and emergency admissions by 2.9%. However, when we reflect on November's data, the latest data available to us, again we see the ongoing trend of the breakdown in emergency admissions being chiefly 0 length of stay, so that clearly supports the work that we are doing on same-day emergency care, where instead of keeping people in hospital overnight, they're able to receive diagnostics at the time of need and are able to receive the care they need and then go home and sleep in their own beds. The breakdown for November in the increase was 7.3% for zero length of stay versus 1.2% for patients who needed to stay in hospital. So I think that's a very welcome sign. I think the other thing to draw people's attention to is that whilst we have seen challenges in delivering the 4-hour target during 2019, and when we look at the overall numbers on it, during 2019 we assessed, treated and admitted 150,000 more patients than we did the preceding year. So just for a minute, I'd like to draw the board's attention to some of the work that's being done on the wider range of services that now sort of make up the emergency care offer. Looking first of all at 111, and again looking at December, 111 received 1.8 million calls year to date. April to December, the actual increase was 850,000 calls. So 1.8 during December, but when you look year on year, 850 of a difference. And for those calls during the month of December, 111 was able to provide clinical advice for more than the 50% target. Interestingly, at the end of October, beginning of November, we launched our community pharmacy offer, actually on the 29th of October, and between the 29th of October and the end of December, 85,000 patients benefited by that. And these would have been patients otherwise who would have ended up either going to a GP service or coming to an emergency department. 111 booked appointments, the analysis that we have been able to do now that 111 can book into urgent treatment centres, into GP practices, etc., indicates to us that about 39,000 more patients are benefiting by booked appointments, and that these are patients that would have previously gone to our emergency departments and indeed would have been counted within the 4-hour metric. So again, transformation and how we are counting 4 hours, not reflecting the overall work that we're doing. During December, the ambulance service received an additional 88,000 calls, and during that month they were able to maintain a Cat 1 performance of 7 minutes 35 seconds, which I think is quite remarkable. Ambulance services during that month also managed to reduce the conveyancing rate by 2% to acute hospitals, meaning that approximately 16,000 less patients were actually transported to emergency departments and instead received the care they needed out of hospital. We continue to see the growth in same-day emergency care, as I referred to earlier, and by the end of December, 90% of our hospitals were providing same-day emergency care 12 hours a day. The final sort of stat that I'd like to draw people's attention to is staff vaccination as far as flu is concerned. And up until the end of December, which is the latest numbers we have, we vaccinated 48,000 more staff than we had done the previous year. Clearly, we're still waiting for the January numbers. And as in previous years, for the month of November, December and now into January, we've had our operational arrangements in place, and as Amanda referred to earlier, the National Ambulance Coordination Centre has played a key role in those. We've also had meetings of the NEP committee, which was established 2 years ago, and they've been very supportive and helpful in making sure that we're able to have a good clinical dialogue on what's taking place around urgent and emergency care. And again, referring back to Amanda's comments on beds, from mid-December onwards, we've been able to provide 1,000 more beds than we did the previous year. I'll just move on and mention RTT. So as far as elective care is concerned, when we reflect on performance year to date, we see that our demand growth for elective care is actually very low. It's set out in the paper 0.8%. Interestingly, when we look at the size of our total waiting list, we see a decrease from October to November of 31,000. And year to date, 2% more patients have had elective admissions, so clearly we are able to offer more care. And I think the important stat is completed pathways had increased by 2.9%, so again linking into the that issue. Again, referring back to Amanda's comments on 52 weeks, we see a 60% reduction in the number of patients waiting for care after 52 weeks. From the peak, which was June 2018. So the actual number at the end of December was 1,398. And in parallel to this in parallel to the work that the Outpatient Transformation programme is now taking on, we are continuing to do the day-to-day outpatient practical work around some of the issues that we have talked to you about before: video consultations, capacity alerts, first contact practitioners, etc. I think that's it from me.
Do you want to comment?
Thanks, Ida. I mean, it's a question really for Amanda or Paulie. I mean, given your experience, having been in sort of the hot end of sort of NHS care for, well, I won't say how many years it's been, Pauline, but some time. I mean, we clearly have per capita fewer beds and fewer doctors than most countries in Europe or in the US. So you can argue that we have a supply problem, if you like, a capacity issue. But equally, I think we're all convinced that we can reduce the demand or stabilise the demand going into hospitals by delivering more care digitally or outside hospital. I mean, where do you think the balance of the argument lies between supply and demand?
So I think the whole urgent and emergency care agenda is to try and ensure that people receive care where it's most appropriate. And very often that means in the patient's home, etc. Very often it means out of hospital. So the work that we are doing is clearly focusing the transformation programmes on trying to avoid the need for an inpatient attendance, hospital attendance or an inpatient admission. We are trying to understand in greater depth why patients select different services, and we are actually doing a piece of work during January asking patients in a number of departments around the country. But I think from a capacity point of view, as well as increasing the capacity in all of those out-of-hospital services, and that's the agenda we're delivering, we do recognise that we need to be able to maintain more beds in the system for now. And that's core to this year's work, that the beds that we're opening over the winter period, we are hoping to keep in place throughout the year. Clearly, we will keep that under review, and as some of the out-of-hospital services do better, there will be less need for beds. But right now, we feel we do need to increase our bed cohort, both up until next winter and then probably further during the winter period.
I wonder whether, I think we're all very acutely aware of how hard our people are working across the country. I wonder whether Steve and Ruth, you'd like to comment for our clinical staff across the country, how things are feeling and what we should be doing to support them.
Absolutely, and nurses, doctors, AHPs and our non-clinical staff are working extremely hard as well. Our porters, our ambulance drivers, whoever they are, they're working extraordinarily hard. And that's why I'm pleased to see that we have had an increase of nurses from this time this year compared to this time last year, and the same with healthcare support staff, but it's not sufficient, and that's why the people plan and the launch of the people plan soon is going to be really very important. And that's why I'm concentrating very, very hard on 3 key things really, which is how we retain our staff more, how we recruit our staff, not just here but also internationally, and how we welcome our colleagues from across the globe. And I guess the third bit of my concentration is about how we increase that undergraduate supply for the future. It's not just about the here and now, but staff are working very hard, and I'm amazed just by the sheer professionalism they still work with under their massive pressure.
So I would concur with everything Ruth has said. A few additional points. So particularly for those staff working in our emergency departments and our emergency services, last summer didn't provide the respite in quite the same way that previous summers have. And so they went into this winter, I think, with a relentlessness of pressure that they had not seen in previous years to the same extent, driven by the demand that Pauline has noted, and the fact that they managed to see many more patients within the existing 4-hour standard, I think is testament to the hard work. And then the second point is, although the weather has been relatively mild this winter, the flu season came earlier than last year and earlier than many years in December. So that peak of flu occurred at the start of the winter period rather than last year when it occurred around this period in winter. So staff also had to deal with that at the same time.
Richard.
We concentrate quite a lot at these meetings on the urgent and emergency care for obvious reasons. But one question I want to ask about around the elective care side is, I've noticed the last couple of times we've looked at this, we're starting to see a reduction in the level of GP referrals, and the extent to which what do we understand about why that's happening?
Amanda, do you want to? Or Pauline, would you like to?
So Richard, I think, again, that is linked to some of the transformation work that's taking place. That there are. So
this is I guess my question is trying to get to: is this good reduction in referrals or not good reduction in referrals?
No. I think again, what we're trying to strive for is that if patients are referred, that it's appropriate and that there aren't other options available that help patients without them needing to come to hospital, or indeed without them needing to see consultant staff in hospital, etc. And I think that this is starting to reflect some of the transformation work that's being done and the other offers that are available, and that's everything from video consultations right through to having more diagnostics available, etc., without needing to come into hospital.
So this would be what I would describe as good reduction as opposed to bad reduction. That was. Okay.
Simon, did you want to?
Well, we've got a desirable increase within that minus 0.8% reduction year to date in GP first referrals. And the desirable increase is obviously, for example, urgent cancer checkups. And so those are going up by between 10 to 15%, but in aggregate we're down by 0.8% at month 8. And that's because of alternative service models, things like the first contact practitioners in musculoskeletal services that have been invested in a number of parts of the country, the other ways of getting a specialist opinion that Pauline talked about. And as you will see when we get onto the planning guidance conversation for next year, obviously a big part of the pathway redesign is around what we're doing on outpatients, which should have a further impact in the positive direction you're talking about.
So if we look at the mix within that figure, the things that we want to be going up are going up, the things that we don't want to be going up are not going up. That was my...
I think broadly that's right,
So actually, on a similar theme, because I was intrigued as to, so if that's going down, what's going up in terms of referrals? What's causing the overall growth? Because I think there's about 4 or 5% growth in other things. I'm intrigued in that. And then secondly, I think the extent to which we do a great job on understanding RTT, A&E, etc. But I'm struck by the absence of similar data on what most of our people, of our patients and population actually experience, which is community care. And I want, whether it be waiting times, where there is big dispersion, whether it be the join-up between various services, whether it be mental health as well as physical health. And I'm just intrigued as to whether we think we've got a forward-looking view on how the performance in aggregate of our community services
And in particular, what is also driving some of the growth? There's two questions there.
David, I'm assuming you mean primary and community
I do,
care.
yes. Sorry, I'm using that in the broadest sense.
I wonder whether we should ask Ian to just input first and then go on to Pauline.
So I think it's a great question, David. We have a relative absence of data in relation to community health services at the moment, and we're introducing a new community services data set. In primary care, if I can just give you the example around appointments data, we introduced 18 months ago a new NHS digital data set. It's not fully complete, and we have a new process. We've been working with NHS Digital and the BMA to introduce a much better data set, which we are discussing as part of the GP contract arrangements, that will enable us to get a much clearer handle, and indeed local practices and primary care networks on variations in waiting.
I'm really pleased to hear that, Ian, because I think sometimes primary and community care is a little bit of the poor relation, or can come across that way. And I think one of the great achievements of the last few years has been shifting money, much more money, into primary care and community care. You can have an argument about whether it's enough, but there is only so much to go around. And I think recognising the work that's been done there, but also starting to understand the drivers and how we can impact channels so that people use different channels to access different services, and how we can start to help those, will only start to be really informed by better data. And our focus, that's the other side of it. We have to keep our, I think, really strong focus on that activity.
So two specifics. So one, the work on digitising primary care and providing support. We agreed last January a set of steps where primary care will be switching on digital services, making available video as well as digital appointments contractually by 2020-21, and that programme is proceeding apace. And then the second is on the capacity expansion, and later we'll come on to the planning guidance. The critical thing is getting the investment for the extra staff, and then the whole of the NHS focusing on helping primary care networks to be able to get the additional staff in additional roles, and critically the 6,000 extra doctors working in primary care.
And where's the growth in referrals outside of GPs?
So I think clearly we still have consultant-to-consultant referrals taking place in the system, but we also have designed some new pathways that are leading to direct referrals. So, we mentioned same-day emergency care earlier on. Patients can now be referred via same-day emergency care for normal sort of consultant referrals, etc. So some of the new pathways are generating some of the referrals as well.
So, okay, all right.
Yeah. But we think appropriately.
I think you make a good challenge, David, that we as a board need to just keep making sure that we are giving the same degree of scrutiny and challenge to primary and community care as we have historically focused on, which is the core.
Yeah.
And I think we take that away and make sure that going forward we really are. Okay. Any other comments? Well,
this may be something for the next session in terms of the planning guidance for this year, but to return to Ruth's comments and Steve's comments around staff and how hard staff are working. I mean, this is the same conversation we had a year ago about, staff working to the max, etc. What comfort can we get that the people plan will help to address some of these issues so that, this time, this coming winter, we won't have the same conversation? Is it worth exposing that a bit more?
I wonder, Ruth, do you want to kick off? You alluded to it, but it'd be worth being a bit more explicit.
Absolutely, and thank you. So, Prerna, our Chief People Officer, and across all of the AOBs, we've been working very hard over the last year developing the interim people plan and the core offer within that. And what that means for me is that we're wanting to make sure we look after people, we look after their well-being, their health, and their environments that they're working in a much more positive way than just what we had perhaps been doing only in pockets within the NHS. There are organisations across England that do this superbly, and what we're wanting to do from the people offer is to make sure that's consistent across all specialities, all organisations, and wherever you work, whatever you're doing, you're getting that superb offer.
Thank you.
No, clearly, I should declare my conflict, as it were. It's sort of chairing the work on the people plan, but there are a large number of people working very hard now in turning the interim people plan into concrete action. It's encouraging to see money behind that in terms of expanding the domestic supply for undergraduate nurses, but actually the most immediate action we can all take is to treat our existing staff better, which is what Ruth's pointing to, and I think there is a momentum building to take that much more seriously everywhere. Steve?
Treating our staff better and ensuring that they don't have things that irritate and get in the way of what they're trying to do is really important. But numbers of staff are equally important because, of course, if you are working where you are understaffed, where there are agency staff who may not be as familiar with permanent staff, is another source of stress for staff. So the numbers bit of the people plan is important, which is why the expansion of nurses is so welcome and so necessary, why the expansion more for the long term that's currently undergoing in undergraduate medical school places is so important, and why actually things like the deployment of additional staff, 26,000 into primary care, because those are the staff groups, the pharmacists, the physiotherapists, who will do a lot of the preventative work that will actually then take the strain off our emergency services. So staff numbers and where they are is really important in this as well.
I should say also, maybe Emily would like to comment on this, we know we have an obligation as an employer ourselves in NHS England and NHS Improvement to work harder on supporting our own staff internally, and very much now having, as we bring the two organisations together, that's the focus of work going forward, isn't it?
That's right. So we've done a lot of work with the whole organisation to understand from colleagues what's most important to them and what we can do to make this organisation a place where everybody can do their best work. And over the last 6 months in particular, obviously worked very closely with the people team to make sure this is lined up with the core offer and the people plan so that everything will be coherent. And we had a very productive session at the executive last week to review both the sort of longer term plan, what we're aiming for, but also some immediate actions for the next few months, which the executive backed and committed to. So we're already doing a lot of the work in terms of improving some of our internal processes, reducing bureaucracy, but a lot more to do going forward. And I know the HR team and the operating model team are keen to press ahead with that with all due speed.
Good. Any other? David?
Just one other question, Ian. There's a fact in the paper which is interesting, showing that 85,700 patients have been redirected by 111 to community pharmacy. I mean, that sounds like a lot of patients, but put it into perspective. Is it a lot of patients? Is it a...
For a new service, we're really pleased with the initial mobilisation phase. In context, there are over 310 million appointments in general practice every year. The previous estimate is that potentially 20 million appointments could be diverted into community pharmacy. Our wider plans here are around a bigger build-up through the community pharmacy contract. The initial work is with 111, and it's, as Pauline said, specifically around diverting patients who would have otherwise gone to A&E or to a GP practice. And at the moment we have piloting work which is coming to a close of whether we can have an effective diversion system from general practices direct to pharmacy, and to also expand to other settings, including diversion from A&E departments to community pharmacy as part of a fully integrated channel management approach.
So the thing I'd like to build from that is that, we've described this afternoon how a great deal of our focus is around what goes on in hospitals, and increasingly we need to and are focusing on primary and community resources, building those, creating more channels and so on. I think the bit that we also need to have clearly within our sights is the upstream piece from that, which is supporting patients and families to do more for themselves by deploying technologies and new approaches, so that people are empowered, enabled, supported to make decisions and take control of their own health. And that's something we've talked about for a long time. And whilst I absolutely welcome the multi-channel approach to primary care, for example, and the video consultations, actually when we think about how other sectors have modernised, banking wasn't transformed by having a one-on-one with your bank manager or your bank clerk over the phone or internet. It was about putting tools into people's hands on their devices, their phones, so they could take control of their money. And we need to obviously be exploring very actively which aspects of that we can apply to people's health. I know we are doing that, and maybe you could say a bit more about it.
So we're doing exactly that in relation to primary care, including through the digital work, and we discussed, I think, in October what more we can do to support that work. I'm also reminded that it was almost exactly a year ago today that we discussed and launched our approach to personalised care, a really critical part of the long-term plan. And the NHS comprehensive model of personalised care, which has 6 elements to it, including shared decision-making with patients, social prescribing, where we've been making really big strides and engaging more and more partners behind that. It feels like a big social movement. We're also funding the social prescribing link workers as part of the 26,000 staff. And also personal health budgets, where we are significantly ahead of our plans and the mandate goal set by government. We had about 2,000 patients with personal health budgets 4 or 5 years ago. The latest numbers are over 50,000, and we are on track to deliver early. And we heard a year ago from patients for whom that has been transformational.
Yes, fantastic, thank you.
I was really pleased to hear that a quality of life metric has been introduced into cancer care. I just wonder whether somebody can give us some perspective on how it worked and what the plans are for national rollout, because that's a really positive thing to happen, because it's normally just been used in clinical trial, but to have it in clinical care is a good metric to have.
Steve, is that?
I can't, but I will get that to you afterwards. That's okay.
Great. In which case, I think we should move on. Oh, Pauline, would you like to?
Just to say one final thing to finish, I think we have made references to it throughout the session, but just to absolutely acknowledge the work of our staff, and all of our staff, our clinical staff, our managerial staff, staff who work out of hospital, in hospital, etc. And, you know, I think it's just unbelievable the amount of sort of tireless work they're putting into all of this. And I think one of the things that I have noticed increasingly over the last couple of months is that the more they are engaged in deciding what the future looks like and informed about those steps, etc., the more they're encouraged to give us even more. And I think we are getting better at doing that. But for now, to really, really acknowledge what people are doing.
I think we all completely concur and agree with you. Thank you for saying it so beautifully. It's also a very nice segue into the looking forward and the next item on the agenda, the operational planning and contracting guidance for 2021. This is the first time we've done this as a combined team, and certainly from inside NHS England, NHS Improvement, it's been quite noticeable to watch a unified team working on this. So I just wanted to say well done to the team who've done that. It also, I think, means there is an awful lot in this document. So I just wonder if, Julian, if you're going to sort of kick off, if you could just pull out the big messages within it that you want us to focus on.
By the way, our aim is to publish this today.
Right.
And Amanda may want to say some more. I think the really big messages here are, firstly, a real focus, to go to a bit of the earlier conversation, on genuinely now improving the sort of core operational performance and making sure that there is the capacity, in particular the bed capacity and the nursing capacity to go with it, that will be required over this year. And I think Amanda may well want to say some more. Secondly, is now seeing through the delivery of the kind of long-term plan goals that systems have signed up to as they have developed their medium-term plans. You know, this is now year 2, And as we've just been talking about, we will continue to insist on the delivery of the mental health investment standard to continue to see the improvement in mental health performance that we've seen and the increase in the kind of workforce in that area, and seeing through the investment in primary and community care as we grow that number by about £7 billion over the next 4 years, and the GP contract negotiations that are ongoing and the increase in staff that Ian has referred to is absolutely critical to that. And then we are in here flagging some changes to the financial architecture, in particular that where systems and organisations agree financial trajectories with us, we will provide the income to cover all of any agreed deficit. That means that all organisations, if they hit their plans, will be in financial balance, rather than a system where some of that was covered by loans and people paying interest. So effectively, the hole was sort of getting deeper. So, you know, giving just the next bit of help to sort of recapitalise the whole system. Secondly, though, the provision of that support will be dependent not just upon organisational performance, but upon system financial performance. So 50%, so the receipt of 50% of that help will be dependent upon system financial support to just continue to encourage and incentivise commissioners and providers together to make sure we are delivering a financially sustainable and operationally sustainable plan. Thirdly, that we will pay that support at the start of the quarter, so that we actually help the cash flow management issues that trusts otherwise have, where they kind of borrow money and then we give them the cash at the end. And finally, although the planning guidance is not yet in a position to set out the detail, we are in ongoing conversation with the department and the rest of government about how, as the process of kind of recapitalising and creating a financially sustainable platform for the whole of the NHS, whether we can still get to a point where we would be able to effectively do a debt for equity swap on historic debts that have been incurred where deficits exist. So it's just worth flagging that's not yet fully agreed, but we are still in the process of discussing that with the rest of government. I don't know if Amanda wants to say any more on the operational side.
Thank you, Julian. Yeah, so just to build on what Julian said, I think particularly the point about the way that the financial framework is now shifting to emphasise the importance of systems. That's something that is kind of writ large, I think, throughout the whole of the planning guidance this time round, that we're using the term moving to a sort of system by default model. So we've talked in the long-term plan about all systems becoming ICSs by what would be the end of next year. So very much seeing this year as a kind of transformational year, but at pace. And the obvious opportunities there, this is the sort of second point, linking to the conversation we've just had, is the opportunity for systems to do some of that more transformational work, because it's the sort of thing that can't be done easily, or indeed sometimes at all by individual organisations, institutions working in isolation. But as soon as you start talking about people coming together within systems, some of the opportunity to join up, exactly what David was challenging us to do earlier, that conversation about primary and community care. We're talking about prevention, we're talking about population health, as well as talking about acute hospitals and specialised services. So that's sort of written throughout the document, is that shift to system by default and increasing focus on collaboration and integrated care. And of course, written throughout the document is the recognition that this is building on the long-term plan. So this is all about doing those things we have just talked about, which are about changing the way that we provide our kind of core business so that we are kind of fit for the future, but that we are also widening the horizons to focus on some of those other things that perhaps haven't traditionally had the same sort of airtime or focus. Saying that, there are some critical messages in the planning guidance, also, as Julian says, about core delivery. So access, quality, money. On those things, just three things I just wanted to call out particularly, we've had an extensive conversation a moment ago about urgent emergency care, but we are highlighting in the documentation this point about occupancy. So the NHS, we know all the evidence suggests you can't run efficiently if you're running much above 92% occupancy within hospitals. So we're going to have to do something that recognises that pressure today, as well as the sorts of changes Pauline talked about that will hopefully take us to a more sustainable place long term. So a real focus on keeping those additional beds that are in the system now open, as well as doing those things that focus on community care, on admission avoidance, on length of stay, that allow us hopefully to find a sustainable way of delivering that level of occupancy. Secondly, on waiting times, again, we've talked about that in detail, but two things just to call out. A big focus in the documentation about outpatient transformation. So for all the reasons that we've rehearsed in detail, but this year needs, I think, very much to build on those really good early pilots, things like the first contact practitioners, things like the rollout of advice and guidance, and start to see kind of real implementation at scale and at pace. The opportunity this year is probably more about using the capacity that's created through that work to bring forward some of those patients who are currently in the queue, so that we are reducing waiting times and reducing the waiting list rather than reducing the overall number of appointments. But over the next 5 years, clearly we'd expect to see that shift. And then the other thing to call out on waiting lists is we are making a point again about systems working together to use their capacity flexibly, so that we're asking people to think together about how to make sure those really long wait patients are catered for well within that 52-week timescale, and also rolling out choice at 26 weeks. So that's the other kind of key component of making sure that we've got people and capacity in the right places. And then finally, the other thing that's writ large through all of this today is this focus on workforce. So, and it is both, Steve and Ruth's points are completely right, written in. It is absolutely about a focus on recruitment and having the right numbers of people and the right places, but it is also about us being the kind of place to work that makes them want to stay. And those two things have to go hand in hand if we're going to be successful.
Brilliant. Thank you.
Comments, Michelle?
Thank you. Health came up as a key issue during the general election, and obviously has been given significant priority by this new government. I mean, what's the simple message to the public about the plans that are in place, and what's the change that they will see and experience?
Well, I think the simple message is that to will the end is to will the means. And the means by which we will continue to improve the National Health Service are by expanding our workforce and tackling some of the deep-seated workforce pressures that exist across the service, hence the fact that we're going to have 50,000 more nurses. We're up 7,000 whole-time equivalents over the last year. We're going to be very specifically focusing, in the way that Ruth said, on further net increases in nursing numbers during 2020-21. Combination of the extra undergraduates who are going to be supported by the financial package that the new government's making available, the retention work that NHS Improvement was already leading, and a beefed up national, international recruitment effort for nursing and other disciplines. So more staff, better infrastructure, facilities. The shorthand for that was 40 hospitals. Obviously we need a multi-year capital settlement. That's a discussion which will be going on between now and the spending review, but which is vital to underpin those ambitions. And then what does that mean from the public's point of view? Well, if we've got 50 million more appointments in general practice, backed by 26,000 additional primary care professionals and 6,000 more doctors in general practice, that will improve experience. But those are all really means to the end, and the end is what we set out in the long-term plan. So the point about the planning guidance here is that for most people across the NHS, this is really confirmation of the work that they've been doing over the course of the last year. The three things that are perhaps new, as Amanda or Julian have pointed out, a very specific focus now on having extra beds in the system and open next year, building on the increases we've seen over the winter. In order to do that, we need the extra nurses, and in order to get that right, we've got to get financial stability into the system, where we made good progress over the last year. But as Julian said, we are restructuring trust historic debt, and we are writing off CCG historic debt. So the inputs to get us the outputs, the long-term plan improvement, and the next year being the next period along this 4-year journey to get the whole package implemented.
Thank you. Dave?
I think it's a question for you, Amanda, or for Simon, actually, is that in a way I think that this is the year where we irreversibly move away from the main unit of accountability being the hospital or the institution to being the integrated system, which requires a very different different style of management, collective management locally. I mean, if you were assessing, just looking across the piece at the moment, where are we in how confident are you that we have the management in place to deliver integrated care systems across the country?
I mean, I think you're absolutely right. I think this is absolutely the year where systems sort of stop being, if you like, the kind of exception, where we've got a moment 11 of the 42 systems that have been sort of got the badge that says they're operating as integrated care systems rather than STPs, and we shift to a place where actually we are running the way we work through systems, and this is this phrase, systems by default. So where are we now? Well, we've clearly got 11 who've reached a level of maturity that's being assessed with the right leadership, the governance and the support in place that's allowed them to reach that level of maturity, and we have others that are on the journey, and there is, as ever, quite a mixed level of variation across those remaining systems. But I think the intention of the system by default model is to say, do you know, if we want to help all of the systems get there by the end of this year, then we're going to have to start working differently right now. And instead of working through individual organisations, which almost gives people permission not to engage, we've got to start working in a way that makes the system absolutely the route in and through to the rest of the NHS. So that's what this sets out, and I think we believe that is going to help us to give the right support and guidance and input to those systems over the course of the next year to get them there. I think what is really helpful about the way we're describing systems at the moment, though, is it does retain the responsibility of the individual components of the system. So this doesn't allow us to kind of lose that granularity of responsibility and focus within something that's just called a system. So the clarity of being able to say, we know what everybody is contributing to the success of a bigger system plan, I think is where we have the opportunity to keep that level of specificity and responsibility and accountability, but knit it together in a way that is greater than the sum of the individual parts.
Richard, you wanted to come in?
Yeah,
and then
just commending the change to the financial framework that Simon and Julian mentioned. We have had for the last 2 or 3 years an incredibly punitive financial framework, and to be blunt, it hasn't worked, and it's sort of taken us all, I think, 2 or 3 years to get to the point of saying we need something more constructive and more forward-looking, and I think what we're getting now does that. It takes that burden of trying to deal with past issues away from organisations that was distraction, and the only thing I'd do is just make sure that we really go at this with a vengeance. This is not stopping here. There's quite a lot more still to be done here, and to really recreate a financial framework that is now about how organisations work together in the future rather than what they've done in the past. So I think we've done a really good first step on that, but there's probably more to do still.
Yeah. Ruth, you wanted to come in?
Just two very quick points. I like the granularity of the plan, because it's been great to talk about. It's really important for recruitment and retention, 50,000 extra nurses. But I like the fact that it's about improving recruitment and retention of specialist cancer nurses even. And that's really important that we get into that detail in order to get positive delivery. And the other thing I'm really pleased is it does actually confirm the final confirmation of the provider allocations for the additional CPD money. And that is going to be very key to ensuring that nurses get their £1,000 every 3 years in order to support their retention and support their education and training. So I'm delighted to see that in there.
So as a board, are we happy to formally approve the planning guidance?
Yeah.
Excellent. Good. Which I presume means it will be published. Good. Okay. If we can move on to our next agenda item then. Henrietta, will you come and grab a chair? Yes, or do you want to come in? Is that easier to be in the middle of the discussion? So our next item is our annual update from the National Guardian's Office. So it's fantastic to have you with us, Henrietta. Thank you. And then we're also going to discuss our own internal freedom to speak up policy. So can I hand over to you first?
Well, thank you very much for inviting me to provide an update to the boards of NHS England and NHS Improvement. And it's a great opportunity to reflect on the changes since I was here last year. And I've been hearing this morning about pressure on staff, and I think it's really vital that workers feel valued and supported, that their views will be taken into account and used for learning and improvement. And that's very much what my role is about. So freedom to speak up is a growing social movement. We've got over 500 trained guardians in England in a broad range of organisations, and we've actually trained over 920 people, including exec leads, non-execs and champions as well. We've got guardians in trusts and foundation trusts across England, but also in the national bodies such as NHS England and Improvement, in primary care organisations increasingly, and in independent sector providers. And last week we published our data report where we showed that there'd been a 73% increase in the cases that have been raised to guardians from the first year to the second year of our data collection. And once again, a percentage of those cases, 41%, were related to bullying and harassment, and 29% to patient safety. We saw that there was a reduction, a welcome reduction, in the numbers of anonymous cases, down from 18% to 12%. And we believe that that's about a growing confidence in people sharing their details with the Freedom to Speak Up Guardian, even if they want to remain confidential. But worryingly, the detriment people that have experienced or it's been reported as is still at 5%, and that's the same as it was in the first year. So that's something that we're really focusing on with our partners. And today we published the Freedom to Speak Up Guardians survey, where we found that 44% of guardians have no ring-fence time. We think this is really worrying because guardians carry out an incredibly important role, not only reactively when people come to speak to them, but also proactively in their organisation. Guardians feel that they are valued by those who they support and by their senior leaders, but less so by their middle managers, and we're really interested in that. But overall, guardians agree that freedom to speak up is making a difference, and that's gone up from 68% last year to 76% this year. So I think it's absolutely key that guardians are given the time and the support that they need to do their role effectively. And last year I wrote a letter to all chief execs across England with guardians regarding this, asking that they have a conversation with their guardians to ensure that they are getting the support that they need. And at the National Guardian's Office, not only do we provide support and guidance for guardians, but we've also negotiated that all guardians are able to access a 24-hour employment helpline. Well, it's like an advice helpline outside their own employers and outside the advice they get from the National Guardian's Office, so that they've always got somewhere to go. Once again, we've looked at the perceptions of freedom to speak up guardians and how that relates to the ratings as done by the Cqc. And we found that guardians in the trusts providers rated outstanding have much more positive perceptions about the speaking up culture than in those rated good, than in those rated requires improvement, than in those rated inadequate. And once again, we found that the perceptions of guardians in the national bodies are on a par with the trusts and organisations that are rated between inadequate and requires improvement. And I think this is really important because it's something about the culture of all the leadership organisations and how that impacts on the culture of providers. We've also looked at the demographics of guardians, and this was something we looked at particularly last year. What we found was that we do have a higher percentage of guardians reporting that they have a disability, which is 20% of guardians compared to 3% of the workforce, which I think is very interesting in itself. But there's, again, a lower representation of guardians when it comes to the diverse ethnicity that we see of the NHS workforce. And so we're working with the Workforce Race Equality Standard team to get a deeper understanding of this and to understand whether it actually impacts on the ethnicity of workers who are speaking up. I think what I'm saying in conclusion is really that leadership is fundamental in fostering positive speaking up arrangements. And so we're working with CQC to strengthen the well-led inspections, and that's with a particular emphasis on ring-fence time and on detriment. But I've been talking a lot about numbers. The stories behind the numbers are what people find fascinating. So we'll be publishing a report called 100 Voices, which sets out examples that guardians are dealing with, and also that workers have submitted to us, including wanting to share their names in those reports. Alongside our annual report, which will be laid before Parliament this year, we will be sending this to all board members. And I recognise it's a bit unusual this year that I've come without my annual report, but because this is being laid before Parliament, the timing of that is somewhat out of my hands. But essentially, the acid test is the view of workers. And I was really delighted that we published a metric called the Freedom to Speak Up Index last year, where we took a subset of questions from the NHS staff survey, and then we, by creating a single percentage point, we were able to say to Trust, this is what your workers are saying. And because it's the same questions year on year that goes to the whole of England, we can look at trends. And what we've found is that 180 trusts improved in their Freedom to Speak Up Index score over the last 3 years, and that there was a 6 percentage point national improvement. We looked at the who was the most improved trust, and I really want to give a shout out to London Ambulance Service, because they had an 18 percentage point improvement in the views of their workforce about feeling supported, encouraged and secure in raising concerns over 3 years. We looked at the Cqc ratings of the organisations alongside their Freedom to Speak Up Index scores. And what we saw was at the top, the trusts who had the highest scores were all either good or outstanding in well-led and overall. At the bottom, it's a little bit more complex, but I think that's something we're really interested in, and this data will be going onto a new culture and engagement page on Model Hospital, so that not only we can look at new insights into the information which is going to be most useful for organisations, but also it means that the trusts can actually look to see who's doing really well in this and approach them for support and help. We've got a lot of comms activities, including our annual Speak Up Month, and thank you to all people from NHS England Improvement who supported us in that. We've also got a new independent website, and we've got a new case review arrangement, recognising the fact that things are very different from where they were 3 years ago. This is to enable the cases referred to us to be addressed in a number of ways and to ensure that the voice of workers is heard. To date, we've published 7 case review reports, we've made 95 recommendations, and we expect that all trusts look at the recommendations to support their own learning and improvement. But one thing I would say is that the most frequent recommendation that we've made is that the trust's policy should be in line with the national minimum standard. And I know that there's a revised national policy that's going to be coming out, but I think what really matters is that it requires effective implementation. There is no single way to get effective national implementation. But my role is to identify and align all the levers to promote positive change. And that includes the behaviours of all leaders, as described in the People Plan, regulatory levers and incentives. So what's new? We heard earlier about systems and joining up the conversation between primary, secondary care, community care and independent sector. And I'm really delighted that NHS England Improvement have agreed to making our funding recurrent so that we can continue to work with primary care and regional integration. We're working with a number of vanguard organisations who are in general practice and in a local medical committee, defence primary healthcare services, but also working with national leaders in general practice, dental, ophthalmic and pharmacy to describe some models and look at regulatory alignment. We have appointed some regional leads. We've got 6 regional conferences in March, and thank you again to all the people at NHS England Improvement who've agreed to speak at those. But this is really to bring guardians from across the patient pathway so they can start having really helpful conversations about looking at those gaps in care. I'm a GP, as you know, and so those are like my everyday happening when I'm seeing patients. I think one of the things Di Harding asked me to be challenging. so I am going to be challenging. What I've seen is that their people are becoming very, very articulate in describing compassionate leadership. We have the rhetoric here, and we have the lived experience here. And what I want is to bring the lived experience all the way across to the lovely rhetoric. So my priorities are to continue to provide support for guardians, understand the impact of their role and to develop new insights, to work with primary care and integration, and to provide training for guardians, workers, managers and leaders. And so as members of the board, I would look for feedback from you about our training when I come back here next year, so you can tell me whether you thought it was any good. And as a system, I really want the ambitions of the people plan to create that joined up approach so that speaking up becomes business as usual.
Thank you. Definitely challenging. Simon, you wanted to...
Well, it was first of all to thank Henrietta very much for her continuing leadership, and as she says, we have re-upped on our financial contribution, which I think should provide certainty for the Freedom to Speak Up office. But I had two questions actually arising from what you said, Henrietta. The first was around the lack of BME Freedom to Speak Up guardians across the NHS. We took a view in NHS England Improvement that we would have at least a third of our Freedom to Speak Up guardians would be from a BME background, given the differential experience of our black and minority ethnic staff here in NHS England and Improvement. Do you think that's something that we should be proposing across the NHS as a whole? And secondly, given a number of the recent concerns that have risen about the culture inside some of our maternity units, do you think there is a case for a specific Freedom to Speak Up programme aimed at maternity services?
So I think Freedom to Speak Up guardians act as the lightning rod of an organisation. And speaking up is a relational exercise. So it only works effectively if there's listening up as well. What I think is really important is that organisations who don't have guardians or champions that reflect the diversity of their workforce ask themselves the question, why? Why are those staff not coming forward to undertake those roles? It's a particularly vulnerable role. It's a particularly vulnerable role for anybody, but if somebody's already feeling vulnerable, they need to have the confidence that their leadership will be listening and not using them as the messenger. So that's the first thing I would say. It's not about people not putting them forward. It's about the organisation looking very carefully about their staff survey results and asking their BME network or their race equality network, what is it that stops you coming forward? That's what I would say. The second thing is about maternity. So this is the year of the nurse and the midwife, and I'm really delighted that we have so many nurses and midwives who are guardians. We also know that from our data report that nurses make up 30% of the people who are speaking up. So I do think that there's guardians need to have the time to be able to provide support to their entire workforce. And we know that guardians who have the time are able to go out proactively to the closed parts of the trust, including labour ward, including A&E, including theatres and ITU, and sometimes including the executive corridor. But the main thing about it is that they need the time to be able to do that. And that's why I really welcome the fact that the CQC are going to focus on ring-fence time. I don't think we can ask guardians to do more with less, if that makes sense. So if there is a particular inclination for organisations to have additional support to maternity, they need to think about what the guardian needs to be able to do that.
Brilliant. Wal, you wanted to come in?
Thank you. Last year, I found your work rather inspiring. You've challenged the board, and I'm going to sort of flip it back to you a little bit here, by saying, at what point, or would you perceive the fact that your organisation is not needed as being success? And when do you think we're going to get there? What will be disappointing? But it's 10 years out, and you're still doing what you're doing. Is that really bad? Because for me, what you're doing is the basis of culture is trust, and trust is being able to communicate, and it's two-way. So I'll sort of play it back to you. What would be disappointing for you, so that we can actually understand the scale of the challenge?
So I had a 3-year post initially, which has now become permanent. But when I spoke to people in aviation, they said they've been doing this for 40 years, and they're not there yet. when we look at the movement in the Freedom to Speak Up Index, that's the best proxy measure I've got at the moment. It would take another 10 years to get to a point whereby, you know, the average across the country would be, you know, at the best that it is now. But I don't think that, honestly, the pace of change that we've done now, I don't want that to flag. And often what you see is you see a bit of movement and then it stalls. The main thing is that all organisations and everyone within them have got to recognise the part that they have to play in that. It's not about me moving 1.5 million people forward. It's about everybody seeing that that's what's important for us to be able to deliver compassionate care for our patients and our service users. And it requires everybody to behave slightly differently. But I agree, I don't think we should have to have them, but if you look at all other sectors, whether it's banking or retail, oil and gas, mining, everybody has some kind of additional channel for workers to be able to speak up.
I think perhaps the issue is people sometimes regard this as a journey without destination. The trouble with that is that you don't have a sort of sense of moving forward and achievement. And I completely understand, you know, the length of time you have to have this because things change, issues change, organisations develop. But it's just having a way of deciding for ourselves whether we're meeting the challenge you set up in any way, shape or form. If the index is one way of doing it, I can see that. But for me, it's about just embedding it in the people plan, embedding it in the way that people behave, and seeing how the freedom to speak up is just a foundation for everything else that needs to happen.
Absolutely, and I have drafted a part to be included into the people plan, and I look forward to seeing the final document.
Great.
David and John.
Okay, so first of all, Henrietta, I'd just love to bottle your enthusiasm, commitment, passion, and take it into lots of places outside of the NHS, never mind in it. I think the board probably would be interested to know that, you know, 10 years ago after the financial crisis, actually 7 years ago, the chairs of the 7 largest banks and building societies, of which I'm the bank building society element, set up something called the Banking Standards Board, which was absolutely aimed at getting a consistent measure of culture and then tackling a whole series of issues. They've done a fabulous job, and the biggest single issue there is, guess what? Speaking up. Yeah. And the correlation between a well-led organisation speaking up and listening up, you know, you've got 2 of those and 1 of those, you know, is phenomenal. And board may also be interested to know that Henrietta's team are an export from the NHS, because they're actually supporting one of my large competitors who have some issues in setting up a Guardian system within that organisation, and that is just great. And actually I think others will follow that, because it's working is what I'm told by their chair, so well done. You asked about challenge. I thought you were going to ask a different challenge, because you made a comment about that the ALBs were somewhere between the inadequate and requires improvement on leading. So therefore I was going to invite you to offer your advice to Simon as the Chief Executive of this particular ALB and the board as to what you think we need to do more of.
Well, I've already had that conversation in private.
I'm not sure how I could respond to that. Let me think about that. If you've had the conversation, that's probably good enough. But I would be interested in 12 months' time to ask you then, if I'm still here, to ask the question, did he listen? But I'll leave you not to answer that now, but 12 months' time.
Can I answer a slightly different question,
yeah,
which is about the export side of things? And I recognised very early on that learning from the best in the NHS wasn't going to be good enough. So I set up a pan-sector network where we bring together multiple different sectors.
Everyone has this challenge.
Yeah, everyone has this challenge. I was delighted to be invited to speak at the Investment Association on the SM and CR regulations. And, you know, what we've learned is the John Lewis model, where they have a newsletter that anyone can write into and the manager has to give a written response and the staff get to vote on the credibility of that response. I don't think we're there yet. We learnt about the way that Scottish Energy deal with detriment. We've learnt about the Army Mediation Service, a whole host of other fantastic initiatives that are happening across the system. We do have guardians outside the NHS. We have them in educational. We've got working with the Old Vic, who have a guardian model as well. And I think what we're really about is about sharing and learning. Nobody's got the answer. No. We've all got a bit of it, and it's how we bring it all together.
Okay. Can I just add, Henrietta, how much I value personally your advice to me and to the executive here. You are unfailingly straightforward and direct about what we do need to do differently, and very wise. So thank you. It's really much appreciated. And I hope you hear from us that we know that we've got to change too. You're so right that unless we shift from the rhetoric, which I think we have got quite down pat, into action as ALBs ourselves, it's impossible to expect the service we oversee to make the changes as well. So can I encourage you to keep having those private conversations and keep pushing us? With that, Steve, do you want to pick up the other items?
Henrietta too. And Henrietta and I meet on a quarterly basis, or it's quarterly, maybe a little bit less frequently. And Henrietta and I have worked together for many years in North Central London, so she has challenged me for many years, and she continues to challenge me.
Say respectfully.
No, you challenge quite rightly. And I took over as the executive lead for internal, or executive support lead to support our guardians for internal freedom to speak up at the tail end of the summer. Perena Isar is the executive lead for concerns that are raised from outside the organisation. And really, since the late summer, we've set about doing a couple of things, so the fruition of which you can see today. But I think this is really the start of a journey, and there is much more to be done. And some of the things that we've had in our conversations, I think, are some of the things that we need to do. So really what we wanted to do initially was to ensure that we brought NHS E&I guardians that had been set up a little bit differently in terms of numbers, support and constitution together, and that we provided an overall support package for them. And the policy that we have got in front of you today provides some of that support. And I'd like to thank Henrietta and her team, because we have been in conversations about this with her, and I discussed it with her only at the start of the week. I think it's important to say that what we really want within the organisation, and we've heard the comments about arm's length bodies, is that guardians should be seen within an organisation as having a welcome, legitimate role to resolve issues that are brought to them. And so we don't want, in a sense, issues and concerns to have to be escalated up through the organisations. We want the organisation to give guardians the support that they need throughout the organisation to get on and deal with the concerns that are raised with them. So that's the first thing. This is not a substitute for guardians being supported. And I think the sign of an organisation that is listening, an organisation that wants to improve and that respects its staff, is one that fully embraces the freedom to speak up guardians and what they do. So that is what success will look like. Having said that, there are circumstances where guardians need additional support, where they have to escalate, and where I know from talking to them they would value that additional support, and some things can't be easily resolved. And so this brings together a transparent mechanism for doing that has been agreed with staff side and taken to the NHS executive, and I should say includes the regions. So this is not just about NHS E&I centrally, this is about regional teams as well. I won't say much more about this, but I think it lays out a way in which guardians and staff can be reassured that we are taking this seriously, and where escalation is required, we have a process for dealing with it. There are more things that the guardians need, and some of these will undoubtedly be on Henrietta's list. So administrative support is really important, which is around the time to do this, feeling that they are supported within the organisation. We will be focusing on that in the next steps. Perhaps additional training in particular areas. Guardians have been trained, but there are always more things that we can do to support. We would quite like to go and visit some of the trusts that are really good at this, because I think it is true that many trusts are further ahead than we are, and Henrietta has already offered to facilitate that, and I will take her up on that so that we can do that. So this is the first step, I think, in bringing this together within NHS E&I, but really this is fundamentally
as well said, a cultural issue, and a culture in which people feel empowered to speak up where there is a concern, and where guardians and others are empowered to deal with that quickly, responsibly and effectively, I think is what we are aiming for. Well, I should have said thank you to Kate, who's here. Tom Grimes, who's also a key part of the team, unfortunately isn't here today, but we can collectively answer some questions. And on the BME point, we absolutely need to ensure that as we bring the two, the Guardians and the Champions together between the two organisations, they're constituted a little bit differently, that we maintain that appropriate proportion that represent our staff groups.
Laura, did you want to come in?
But it seems like one of Henrietta's big recommendations is about ring-fence time.
Yes.
Does our policy...
No, and that's something that I want to take forward. I talked a bit about with the Guardians about that yesterday, and it's not just about the ring-fence time, it's about the whole package of support. Because, of course, it's a time to do what, and some of the administrative work and some of the I think we can manage a little bit differently. So yes, we will be taking that forward.
Right. Okay. It sounds like we should.
Yes.
I was going to ask that question. I'm very pleased you did. An add-on. A couple of people have used the phrase, and Prena uses it as well, which is listening up, being actually more important to create a culture that encourages the speaking up. And I wonder whether we should take an action for the board to have a listening up session with our own guardians at the next board cycle in private, so that the guardians feel they can really tell us what it feels like, and set ourselves the challenge, but that between now and then we can live up to Henrietta's challenge, so that they feel they have the time and the resources to do what we're asking them.
I'm sure they'd be delighted, and I can assure you they'll probably tell you exactly what they tell me.
I'm sure they will, but I think it's important that we hear it properly. Okay. So are we happy to approve the policy on that basis? Yeah. Okay, excellent. Thank you. Thank you, Henrietta, and we look forward to seeing you formally next year, but informally probably tomorrow. Thank you. Right, Steve, it's back to you again on the clinical review of standards.
Yes, so the last time I brought an update on the clinical review of standards, I think it was a September board, so this is another update. The paper is there for you to read. Just make a few brief points. So firstly, since last bringing an update to the board, we published an update on the Clinical Standard Review of Standards website at the end of October, right at the end of October, which detailed the work that we had done since we published the interim report in March of last year, and some of the early findings from the field test sites. Secondly, I would say once again thank you to the 70 organisations who are testing these standards for us. I don't underestimate the amount of work that requires in those sites, and clearly in busy periods asking staff to engage in testing is an extra ask, but they have been enthusiastic, they have been engaged, and we have learnt a lot from the work that they have done. So a big thank you to those organisations and the staff in those organisations. So a brief comment on each of the four streams. So on mental health, and part of David's question early on about holding ourselves to account on performance in mental health. Of course, having a set of standards to do that is important, and of course in mental health this largely represents a set of new standards. Mental health was always going to be on a longer time frame because the need to align it with the deployment of resource as part of the 5-year forward view and now the long-term plan, and it remains on a longer time frame both in testing and almost certainly, if approved, in implementation, and therefore we will look to provide final recommendations by April 2021 in mental health. In RTT, which is elective care, which Pauline's talked about earlier, again, we always knew that was going to be on a longer testing cycle because of the nature of the length of that pathway and the ability to test it. But it is also true, as others have hinted in previous items, that the reform of the transformation of the outpatient
service and the outpatient offer, and also work that we will be doing in diagnostics, including some that Sir Mike Richards, who's here today, is doing for us, will interplay with that pathway, as will the 26-week choice work that has also been referred to. And so because of all of those, we have decided to put the RTT work onto a similar path to mental health and to look to provide a final report by April 2021. For cancer, the faster diagnosis standard, which is the main recommendation, was recommended by the task force in cancer a few years ago, so that has been well discussed, and indeed we put it in the consultation around the standard contract a month or so ago with an intent to introduce the standard in April, and we are on track to do that. And then finally, on urgent emergency care, we are now in the process of testing, where we are particularly focusing on the testing of our critical time standards, and those are the set of standards that were recommended last year, which particularly focus on things like stroke and myocardial infarction, heart attacks, and deteriorating patients, including patients with sepsis. So the sickest patients and the patients where we have perhaps the greatest chance to shift the needle on outcomes in terms of patient outcomes in mortality and morbidity. So that's the key piece of work that's ongoing at the moment. We have very good engagement with all our stakeholders, colleges, charities, patient groups, and I'm also really grateful to them for all the work they're doing, working with us on this. And with that, I will say no more.
Excellent. Simon, is there anything you want to add?
I don't think so. As Steve says, this is sort of an end of March, sort of spring set of recommendations for half of it, and then the other half, as previously planned, work continues going into 2020.
Any questions or comments at this stage? Tim?
I just wanted to say, Steve, in this very, very important process, are we getting the balance of the process of developing the standards right? Do you feel like the process is getting the buy-in that is required? If you're going to have standards, there has to be buy-in for those standards.
Yeah.
How do you feel about that?
So, as I said, we are getting an awful lot of support from our test sites, which are the main people who are, of course, living it every day, but also from the stakeholders that we work with. We have an oversight group across a range of patient groups, Health Watch, Royal Colleges, charities, and also working groups in each of the areas, or groups that support each of the areas. So yes, we have, and I think we are definitely learning from the field test sites. So in urgent and emergency care, as it says in the paper, we have learned a number of things over and above the original basket of indicators that we proposed. So it is definitely the case that the field test work is teaching us additional things, and our approach and conclusions are evolving as a result of that.
Great. Thanks. One other question is about pace. So delivery of medical care is incredibly complex. There's innumerable standards you could work on. Are you? How do you feel about Are we making progress at a pace that you feel the public is in terms of our duty to the public? Are we making enough progress fast enough on the development and implementation of standards?
Well, so I think on the testing, we always knew, as I hinted, that the testing phases would be different for each of the 4 work streams. Mental health longer because of the deployment of additional resource into mental health, which we've been undertaking over the last few years and will continue, because ultimately any set of standards is there to support a service model. So getting that service model embedded in mental health is key. For elective care, as I said, the pace we have adjusted because of the testing, because of the length of the pathway and the ability to test in cycles, but also because of the work that we are doing as part of the long-term plan on outpatient transformation
and increasingly looking at diagnostics. Urgent and emergency care, we've been testing since the end of May, and as I said, we've moved through various phases of that. And I'm pleased with progress, but again, we of course are asking staff to test during busy periods of winter as well, which was an important part. So yes, in the round, yes, but I think it is, as I've said, important to note that there's not one single timetable for all of the 4 components of this, and there can't be.
Great. Thanks.
Pauline?
It's just to go back to Tim, your question about staff engagement, etc. And when I made the earlier reference to how motivating it is for staff to actually be really involved in something like this, and that was really with reference to the 14-month, UEC slides, whereby all of the staff who are working in the departments, and indeed more and more staff in the hospital, are getting heavily involved in the work that we are doing, and I think they feel engaged, they feel as if they're being listened to. Sometimes there's debates and discussions on various things, but I really think that's paying off.
Excellent, thank you very much. If we move to the next item on the agenda, Bill, are you going to come and talk to this? So this is an overview to the board on the process undertaken to assess safety and effectiveness at each of the 9 organisations that received services from what was the Liverpool Community Trust. And this is an action from the Cqc report and an NHSI item, strictly speaking. Bill, can you talk briefly to the paper?
I will do, thank you, Chair. Just to remind people, Bill Cqc's report was into serious failings at Liverpool Community Health Services NHS Trust. Just picking up on some of the conversations I've been hearing today, I think David pointed out the importance of having, paying proper attention to community services, and Henrietta's just talked now about the importance of people feeling able, free and encouraged to speak up when they see things going wrong, and this really is a very sad case of how wrong things can go when those conditions aren't in place. So we should, and I will on behalf of the NHS in the North West, apologise again to the people, the patients, the families who were affected by this. Bill Cqc's report was comprehensive. This is not addressing the full scope of what he recommended. It's picking up a single recommendation, which was that we should review after 12 months all of the services that have been transferred to new organisations. And this paper sets out the methodology that we've seen through and some of the fairly high-level conclusions. I think where we are is we've seen improvements throughout. So people should feel safer, more assured when they're using community services, when they're depending upon them in the area covered by the old Liverpool Trust. But we should not be complacent at any point. There is still work to do, there are still risks, and particularly I think we'd highlight the massive task that Merseycare took on, just the volume of staff and the time it will take to really move that culture through for all of those staff groups to feel really safe, really assured, able to speak up very freely. There are encouraging signs. So in the interviews that we held, in the visits that were undertaken by our teams, and indeed looking at the staff survey reports, we're seeing positive movement in all of those areas, and that encourages us. We think we've come to the point where rather than just labelling these services as the ex-Liverpool Community NHS Trust services, we need now to make the step on, so they're seen as an integral part of their new organisations, and therefore we should make the step that with all the right surveillance, the right oversight, the right support, nevertheless we should now use our normal quality assurance and oversight procedures to support the further development in those organisations. So the recommendation is to note the report, Chair, and to support that recommendation to move into a more normal way of assuring quality.
comments or questions? Richard?
It's only a very, very specific one, Bill. I apologise for that. But when you go through the processes undertaken for each organisation to provide the assurance, Solutions for Health, I know nothing at all about. There's not many ticks in that row. Now, whether was that based on sort of the risk assessment in that area, or was it based on the numbers of staff transferred? It just looked a bit odd next to the other ones. Actually, to some extent, the Virgin Healthcare one as well.
It is. It's based on the number of staff, so there are only 10 staff transferred. It was around a specific service, and rather than do visit and intervention, we mostly ran that through telephone conversations with the staff to ensure that they felt they've moved on, and that's summarised then in the annex.
Okay. Any other comments? Having personally visited Merseycare twice in the last 18 months and spent time with staff who transferred over, I think, Bill, you've given a very good summary, and we should not underestimate the journey that those people are on in healing. There is an awful lot of work still to do. I think the work that particularly Merseycare are doing on a just and fair culture is extremely impressive, but that's not to in any way diminish the scale of the challenge. Thank you for the very sensitive way that you've described this. And I think you're totally right. It's time for these organisations to be able to move on and their people to move on. I'm looking forward to actually going up with Rosie Cooper MP to visit HMP Liverpool quite soon. She and I are just trying to schedule that to sort of continue the focus. And I wouldn't want anyone to think that the other actions from the Kirkup review are forgotten at all. They're not. We are quite carefully scrutinising each of them, not least the response to Tom Cqc's review, which we will encompass in the publication of the People Plan. Okay. Thank you very much, Bill. So I think I get to hand over to you, my lord.
So we've got two issues to discuss under specialised services. I think, John, you're going to kick off, aren't you? Supported by David Slobin, and good to see you, Mike Richards, again. We served together in a different place a few years ago. So thank you very much for the work you've done on cancer services in London. But can we kick off with you, John, please?
Yeah, absolutely. Thank you, David. So this item covers two distinct, yet I think linked areas of NHS England's direct commissioning responsibilities for specialised services. Firstly, an update on proposals within London relating to cardiorespiratory services, and then secondly, proposals relating to children's cancer services following a full public consultation last year on new draft service specifications. The thing that links, I guess, these two areas together is the extent to which these services must be co-located with a range of other paediatric services. And we will come on to that shortly. Perhaps, David, once we've gone through those two items, I might also have the opportunity to provide a brief update on a third matter that also relates to children, and that's actions we've taken and set in train recently in relation to children's gender identity services. But if we kick off, first of all, with cardiorespiratory
Actually, John,
services.
sorry to interrupt. I should have mentioned that Amanda has a conflict of interest because of her role at Guy's and St Thomas's. I think the rest of the board of NHS England don't have a conflict. You have a.
Conflict of interest is tabled here on a consultant at the Royal Marsden.
Arrow's a consultant at the Royal Marsden, so has a sort of a conflict there as well. But I don't think it's so great that you should feel that you can't talk on this if you wish to, Arrow.
Okay, so I should be very, very brief, David. I hope the paper is very clear. It's probably take me longer to introduce it than it would take you to read it, so I won't dwell. I mean, the very positive things, this is a follow-up note following the board decisions about the commissioning of CHD services in November 17, when we were charged to go away to see if we could do some more work to take the ambition of the Brompton to work with Guy's and St Thomas's to both implement the recommendations of the board decision, but also to see if we could do something which would even move us further towards genuinely world-class services across the capital, underpinned by in a model which would enable the Brompton to continue to exist as an organisation with that international brand. What you will see there is a consensus position about what the proposal moving forward would look like. The headlines are the 4 bullet points which are identified in para 3 of the paper, which in summary are about support for a series of estates developments around the rebuild of Imperials and the Evelina Children's Hospital, which would enable us to consolidate paediatric and adult CHD services within Guy's and St Thomas's on the Westminster Bridge site in a way which would be fully compliant with the Commission decisions which had been made. Secondly, to move services from the Chelsea site of the Brompton onto those sites within the Evelina and the new build hospital, whilst ensuring continuity of service delivery of both secondary and tertiary respiratory and cardiac services to the residents and patients of North West London, which has been a very important underpinning piece of work. To oversee that, we would establish a clinical transition board that would be jointly chaired by the chairs of Imperial and Guy's and St Thomas's to ensure that during that period of transition we have continuity of service delivery for patients and residents throughout that period of time. And finally, this would also be underpinned by a merger of the Brompton and Guy's and St Thomas's, which would give a sustainable future for the Brompton, but also provide, that, as I say, that platform for the further development of what will be genuinely world-class services to a population beyond the immediate vicinity of those hospitals within London. There is no decision for the board to make today. This is a note. This is a direction of travel. It's an update to where we are, but nonetheless, these proposals do signal a major programme of work, which will broadly focus in three areas. Firstly, it would be the development of the capital proposals that relate to the Evelina, Guy's and St Thomas's and Imperial, and it will be noted that the Imperial capital development was flagged as part of the HP2 programme in terms of the building processes. Secondly, once we have more detail and more flesh on the bones, there would be a process of public consultation that we would need to go through associated with the service moves. And thirdly, we would now charge the Brompton and Guy's and St Thomas's to work through what the next steps of a potential merger would look like. The final opportunity this does present is to encourage our universities across London to see whether or not they can collectively take, as I say, what is an outstandingly good platform to an even higher level as we compete internationally in terms of the way we develop the academic infrastructure that we have. So that's the summary of where we're at.
You want to comment?
I think the trusts involved have come together in a very constructive fashion in the last several months, and I think we are really unblocking a lot of change which has been much discussed across London for a long time now, and out of it could come something really good for North West London as well as for respiratory services and the Brompton.
I think I should also declare that I'm employed at Imperial, that I'm employed number of places. I just wanted to make the point and really thank Simon and his leadership in doing this. These types of changes, reconfigurations, are always very difficult, very hostile. And he single-handed it, brought all the stakeholders together. It was bottom-up, and I just wanted to put that on the record.
Can I just be clear, on the respiratory side of the Brompton, where does that lie between Imperial, between Imperial and Guy's and Thomas's?
Chairman, there are so many things we can spend all day.
A consensus has happened that all of them are very happy, and which is really what I would like to, including, by the way, many of our patient stakeholders who've been involved in this consultation.
Anyone else like to comment on this area? Excellent.
Okay,
right, John.
So
Next on to the next item.
Move on to children's cancer services. So I'll be brief again.
Sorry, I'll stay.
So last summer we launched a consultation on new service specifications for actually both children and teenage and young adults cancer services. And actually to support the board in considering the outputs of that consultation and take decisions on next steps, Simon asked Professor Sir Mike Richards, who's here today, to help us review the consultation responses and make recommendations to the board on the way forward. It's worth saying that Sir Mike's review was particularly focused on the issue of whether or not NHS England commissioned principal treatment centres for children's cancer must in future be co-located alongside level 3 paediatric intensive care services, in addition to a range of other paediatric services. The recommendations in the paper, I think, are very clear, but I'll hand over to Mike maybe to provide a bit of an overview of his report and those recommendations.
Thank you, John, and thank you to the board for inviting me here to present the report today. You've all seen it, so I won't go through it in great detail. As John's already said, I was commissioned to undertake this review working alongside the work that NHS England was doing, and in particular the consultation on children's cancer. I wasn't looking specifically at the teenage and young adult cancers. And the key issue is whether a principal treatment centre for children with cancer should be always located with a paediatric intensive care unit. And the way I've gone about this is, first of all, I've reviewed all the responses to the consultation that came in, which ended in August. I've talked to a large number of experts, parents, charities and others. I've also visited all the main sites in London, which is the most contentious area. But in addition to that, I very deliberately went down to Bristol to see how they did it, because that's a model of a very integrated service. And I've also reviewed previous reports that are relevant to this. As you will have seen, I have concluded that from now onwards, principal treatment centres must be co-located with a paediatric intensive care unit. And I would just add to that, and with a range of other specialist children's services. We often talk about paediatric intensive care unit as a shorthand. You don't have a paediatric intensive care unit unless it's serving a range of children's services. And my conclusion, I may say, was almost unanimously supported by respondents to the consultation. And the reasons behind that are, firstly, to minimise risk to patients and to ensure continuity of care, which is very difficult if the sites are separated, and therefore to minimise disruption to patient care due to that geographical separation of principal treatment centre and PICU function. So that's the generality. I recognise that these recommendations have particular implications in London, and I'll start with the implications around the Royal Marsden Hospital at Sutton and St George's, which, as many of you will know, are about 8 miles apart and 40 minutes drive apart. I do specifically want to say that the clinicians in each of those two hospitals strive very hard to make care for children as safe and as effective as possible, and there have been no recent serious incidents reported. However, the geographical separation of the sites does, in my view, pose a risk to safety and results in children and their parents having to go backwards and forwards between the two sites really quite frequently, and I think that in itself has an adverse impact on patient experience, largely because the consultants or the team that they are under at one site will not always be at the other site, so they're moving between teams. And I don't believe this situation should be allowed to continue longer than is absolutely necessary. In my report, I haven't made a specific recommendation regarding a preferred option for co-location, as I believe that's actually for commissioners to decide, and that was outside my brief. I should say that all the trusts that I visited in London would be happy to host children's cancer services if requested by commissioners. But having said that, I think there are three options that really should be considered in detail. One of those is the Evelina London Children's Hospital, which is the largest children's hospital south of the River Thames by quite a margin. There's the Royal Marsden itself, but that would only be viable if full children's services with the PICU and the other services could be co-located alongside it, and that, of course, is a commissioning decision. And the third option is St George's, which is the other half of the principal treatment centre now. Can I just say a word about what happens north of the River Thames between Great Ormond Street and University College Hospital? And I think the situation there is different. There is only a PICU at Great Ormond Street and not for children at UCLH. But the children treated at UCLH are intrinsically patients with a very low risk of needing PICU. And when I visited there, they went through exactly different patient groups and what the risk of needing PICU is. So, for example, with CAR T-cell therapy, the risk is about 50%. And it's not just that you need PICU, it is that you then also may need access to a whole range of other specialist services. But they look after a different patient group at UCLH, very rarely needing transfer to a PICU. In addition to that, the two hospitals work very closely together and have frequent multidisciplinary team meetings between those two sites. That's facilitated by the fact that the distance between the two sites is really very short. And I looked at transfers between the two sites. The only ones that really crop up are occasionally patients who are having radiotherapy need to get to a site with neurosurgery, and you can't uproot a whole radiotherapy service, particularly now that it's got a proton beam therapy service at UCLH. So I think those two are quite different. So I'm making a different recommendation north of the river from south of the river. I'll stop at that point.
Thank you very much indeed. Any questions for Mike? Aaron?
Thank you, Chair. I have a few questions. Lovely to see you, Mike. It's been a while.
Very good. See you too.
So just for the sake of the board, when you were the very distinguished first Chief Inspector of Hospitals in the NHS, if I'm correct, the Royal Marsden scored excellent in the whole of your tenure as the Chief Inspector of Hospitals in terms of its quality of its services. When we first inspected there, we actually rated the Fulham Road site, the Chelsea site, as outstanding, and the Sutton site as good. Right. We also did look specifically there at the Children's Service, and that was rated good. But that is absolutely consistent with what I'm saying now, which was the care given in each of the two locations. I'm not worried about. Sure. It is the fact that patients have to transfer between the two, and they are different teams. Yeah. So you could point out that that is something that, you know, in CQC's remit at the moment, it only looks at individual organisations, not across boundaries. Okay. One other thing which you this bugs me, I'm sure it did to you when you were in St Thomas's, is it's fantastic. The combination of ICR and the Royal Marsden has scored top when the research excellence framework comes through of any cancer research centre, including Cambridge, Oxford, and to Imperial too. And have you looked at the impact assessment of this stuff? Because there's no question there's a fairly high quality research happening. As I said, 4-star is what they've always scored in the last two refs. Yeah. Any concerns about that?
And I met with the academics at the Sutton site, and undoubtedly they made the case about how beneficial it is to have researchers co-located with the clinical services. I personally think that it's of greater importance that the clinical services are co-located for the patient's benefit. I do think that then one has to make arrangements that academics can move between sites if that's needed, but I don't think that's beyond the wit of man.
One last one which raises chimera, which is, the CAR T therapy. I mean, NHS England's commissioning report will suggest that in B-cell ALL, there is I think, if I'm correct, 50 to 30 children a year will need CAR T therapy. 50% of those will need intensive care services. So we're talking about 7 to 15 children. Do you think within the context of that is worthy of moving and shifting all these services from a centre of clinical and academic excellence to a different site for essentially out of the 715 nationally, there might be 1 or 2 patients? Why don't we just say we will no longer commission CAR T therapy at the Royal Marsden?
I think any forward-looking principal treatment centre needs to be able to give the full range of children's cancer treatments that there are. CAR T is just one example of that I was giving. There are other treatments that have a risk of needing PICU of well over 10% and some that are at 20%. CAR T just happens to be the highest at 50%.
Thank you. Thank you, Mike. Thanks for explaining.
Thank you, Mike. I just wonder if you could draw out, and you've already done it, but a little bit more, the differences between the model at the Royal Marsden and St George's and versus UCLH at Great Ormond Street. So I understand the geography is different in that UCLH and Great Ormond Street are closer, but on the question of case mix, which I think was the other principal thing that you thought of, particularly Ara's comments about forward-facing and thinking about the future, the treatments of the future, including CAR-T therapy. I think you've highlighted the frequency of transfers between Great Ormond Street and between UCLH and Great Ormond Street currently, but with the forward-facing view, does that hold as well in terms of how that service works? I mean, the children who are treated at UCLH are patients with germ cell tumours, Hodgkin's lymphoma, sarcoma, all of which UCLH has particular expertise in throughout the age range, and that's clinically and in terms of pathology and all of that. And these are also groups which have very, very low risk of requiring intensive care. There are occasional patients with sarcoma who have relapsed and who need high-dose therapy. They are all electively transferred to Great Ormond Street for that treatment.
For Mike while he's here. Where do we go from here then, John, on this?
So, subject to the board's agreement, the next steps would be to update and amend the service specification in light of Mike's recommendations. We would do that very shortly with a view to that going live really from the 1st of April this year. Then there is a separate piece of work to be done, which I will now kind of hand over to David in the London region to properly now look at the three options that Mike has kind of presented in his paper about how co-location can be achieved. The recommendation from Mike, which I think we agree with, is that should be done as quickly as possible. You suggested a 6-month time frame. I think the board paper itself is even tougher than that and says June this year, but I think that's the key next step. But in the meantime, obviously the Marsden will continue to be commissioned as a principal treatment centre. We've heard from Mike about the safety of the service both at the Marsden and St George's in the meantime, but we will put a derogation in place that means that they continue whilst we put in place the amended service specification.
Good. So are the board in favour of this? I'm looking at NHS England directors, yeah. Simon?
Well, we've got a clear recommendation from
David?
Mike that requires consultation on the options, as John said.
All right, thank you. And Mike, thank you very much for doing this work. It's
a pleasure.
A real labour of love. Many thanks. Thank you.
So, David, if I may just provide a very brief and verbal update on a third matter that relates to paediatric specialised services. And as I mentioned at the beginning, it's in connection with children's identity services. So this is a service that has attracted much public debate in recent months. And it's also a service that I think we need to recognise has seen unprecedented growth in referrals in recent years. In fact, 3,000% increase in referrals since 2010-11. Back in 2016, NHS England put in place a new service specification for these services, and at that time we committed to conducting a review of the specification and the associated policies for 2020. So we're now at that point. So to support this work, an independent expert group is being established to recommend whether changes may be required to existing clinical policies that underpin the use of puberty suppressants in children and the use of cross-sex hormones in children from around the age of 16 years. I'm delighted to tell the board that Dr. Hilary Cass, who's a former president of the Royal College of Paediatrics and Child Health, has agreed to chair this independent group. The working group will be made up of 20 members from a range of clinical, academic backgrounds, and will include members of the public, and will provide kind of full details on the membership shortly. To support that group, we have also asked NICE to conduct a review of the latest clinical evidence on this matter, which can feed in. And then finally, on top of all of that, and in order to support the development of the wider service specification, we have additionally asked NICE to develop a full clinical guideline on gender dysphoria in children that will help, amongst other things, to identify when to refer children and young people into specialist services. So once both those reviews have concluded, patients, families, experts and other interested parties will be invited to then comment on any proposed changes to the service specification and associated policies.
Thank you, John. Any questions on that for John? No? Good. Thank you very much. Back to you.
Oh, thank you. So is there any other business that anyone has for the public board? I have one very small one, which is just to remind everyone that I think, Jessica, you're about to commence our internal annual board review. Is that correct? So you'll be making contact with everybody so that there'll be a questionnaire to fill in, but also some interviews that Jessica's going to conduct so that we live up to our commitment to review our joint working processes 12 months into working together. That's it. In which case, I think we'll close the formal meeting. David and I are available for any informal questions from anyone from the public. And if I could encourage the board to stay to be able to have a chat with our young carers. Thank you very much.